So let's start, I think, next 15 minutes, some topics about diabetes and how we use insulin. So there are some perceptions, there are some insights when we treat pregnancy, and the fetal outcomes are dependent on maternal metabolic factors as well as obesity. Always we need to remember that. Ethnicity plays a great role, and that's why we face the problems. Everyone is having lot of young girls with hyperglycemia. Everyone we all are treating, because as a South Asian ethnic population, the diabetes background type 2 is much more in our population. So pregnancy and diabetes or gestational diabetes is much higher compared to other ethnic population, which we don't need these figures. We are facing it every day in our clinics. So we know there are lots of problems with the fetal outcomes and the maternal outcomes because of hyperglycemia. Some are related to at the time of delivery, which is related to macrosomia. And let me say 4 grams is not the definition. Above the 90th percentile, it can be 3.2 kgs in our Indian population. So above 90th percentile, big baby, the big liker, shoulder dystocia is very rare because usually it's a planned C-sections. And of course, there are the long-term fetal outcome, which are very important because body composition at birth, the fat mass is 12 to 15% and fat-free mass is 85 to 88% in a neonate. The fat-free mass is mainly decided by genetic factors and also insulin sensitivity prior to pregnancy in mother, paternal height, maternal pre-pregnant weight. So these are some factors which decide fat-free mass. Fat mass of a newborn is decided by mainly maternal metabolic factors, most importantly sugar and triglycerides. These are the 2 mother factors which decide baby's fat mass. At least we know what to intervene and what to prevent by changing this metabolic milieu inside the utero. And why the fat mass is important in a baby? Because at birth, this fat mass decides this baby's future adult obesity and diabetes early in life. So we need to have this fat mass to be precise. As we know, that's the thin fat Indian, this starts right at the birth, and the percentage of fat in an Indian baby is much more compared to a white Caucasian. So we all are born with more fat percentage, which increases because of hyperglycemia in pregnancy. This was published long back from us. So just I would like to explain here. These are the yellow ones are babies born to normal mothers. Red ones are babies born to GDM mothers. You can see this is 90th centile above that is the birth weight, only less than 5% in normal, but 30% of babies born to GDM mothers are overweight. They are above 90th centile, which can be called as macrosomia. When you come to babies' fat mass, less than 5% babies born to normal mothers have a more than 90th centile of fat mass, but you can see 55% of the babies born to GDM mothers, they have more than 90th centile of fat mass. So this is also true for our Indian baby. These are born in KM, that was the cohort. So the mother's glycemic status, you know all Pat Catalano's studies, which actually spelt, and our understanding of type 2 diabetes increased when Pat Catalano presented his pregnant girls' metabolism to us. So fat mass is directly related to the mother's glycemic status. Just to mention, it's not only glucose, but mother's obesity also decides baby's fat mass. So that you can't help. Once someone is pregnant and obese, you can't go back. So again, it tells how the weight and management of young girls before they become pregnant is very important. Just I'm talking about glucose today. So we know that insulin sensitivity goes down and the resistance increases many-fold during pregnancy. At the same time, some hormones which comes from placenta increase mother's glucose. This was a normal physiology to facilitate more glucose or more kind of a food to the baby, which becomes detrimental if mother's pancreas are not capable of taking this insulin resistance, and there is a beta cell insufficiency happens in pregnancy. So these changes are exaggerated in Indian women because of visceral adiposity, lots of PCOD, and of course we know lots of IVF pregnancies. So intrauterine metabolic factor, we know this is modified Peterson hypothesis, and what it shows that high glucose, we all know that this was Peterson, that increased glucose in the baby's pancreas respond to this glucose, that is fetal pancreas, there is more insulin being a growth hormone, baby has a more growth, there is an overgrowth in fetus, and there is it gets converted into fat mass. At the same time, amniotic fluid insulin increases, so there is more liquor which you routinely see on, which can have some implications, short term as well as long term. It's not only glucose, it's free fatty acids, triglycerides, and also some proteins from the mothers. This year's ADA was a very good presentation of correlation of mother's triglycerides and baby's fat mass and abdominal circumference. So again, this goes hand in hand, triglyceride glucose, we all know that this is important. So even in 68% increase in hepatic fat. You are hearing, I think in this conference, we just had a very good session about NASH and the liver fat. And we know that is the beginning of the problems for beta cell dysfunction. So the babies born to hyperglycemic mothers have more kind of a liver fat. So we need to decrease this hyperglycemia. Now, everyone should know HAPO. This, you know, this hyperglycemia adverse pregnancy outcome studies. This was a 7-year follow-up. More than 25,000 women were recruited, diagnosed with standard 75-gram OGTT, and what was studied was correlation with mother's glycemic status and the baby's fat mass or the baby's birth weight. So I will just go to the results. Here one can see here the fasting glucose. We talk a lot about postprandial glucose in pregnancy, but in HAPO, more than 25,000 women data, it showed that how fasting glucose of the mother correlates with the birth weight, cord C-peptide. You know, cord C-peptide is a measurement of fetal insulin. So how much fetal beta cells are secreting insulin is measured by when you clamp the cord before you take the sample, which is cord C-peptide, and percentage of newborn fat. So this has a strong correlation with fasting glucose, 1 hour glucose and 2 hour glucose. So all 3 glucose has a strong correlation with the baby's fat mass. The same thing is shown here in pictorial in the graphic thing, that birth weight and is correlated with not only fasting glucose, 1 hour and 2 hour glucose. So that was the HAPO study. So what the conclusion was, there is a strong continuous relationship of maternal glucose levels, which is true even in the normal ranges, which is very true. So increase in blood glucose associated with baby's fat mass, baby's cord C-peptide, that is insulin levels, and increase in the birth weight. There is an additive effect. If there is a hyperglycemia plus obesity, there is an additive and independent effect of both the things on baby's fat mass. So you need to treat both if you want to reduce baby's fat. This was again a very good continuous relationship, is how this 1 hour glucose is related to baby's fat mass. It's a continuous. So mother's 1 hour glucose, higher the glucose, more is the fat mass baby's, and it is true even in the normal ranges, though it suddenly rises at certain cutoff. So what time you should check the glucose when you are treating mother's glycemia in pregnancy? These are the preprandial values. So when does the peak happens? So this was done in Israeli population, you know that, and this was the 1 hour glucose. The peak of postprandial peak happens at 1 hour, that is 60 to 70 minutes. I think nice study again done from Dr. Sheshaya's group, and that shows that in Indian population, the peak is happening around 90 minutes, not at 120 minutes. So when you are checking the glucose at the beginning of first mouthful of food, usually the PP is 2 hours, you should check between 90 to 120 minutes in Indian population, and I think in some European population they are checking it at 60 minutes, that is at 1 hour. So maybe overt diabetes prior, so again one problem with GDM definition is that any hyperglycemia in pregnancy, we group them as gestational diabetes, but these girls may have diabetes before pregnancy which just gets diagnosed because we are checking glucoses. There are examples, the pregnancy test comes positive, the girls come with diabetic ketoacidosis in ICUs. So we have seen type 1 diabetes coming in pregnancy, there are, at least if you see the follow-up of GDM women, you know that certain percentage of patients develop type 1 diabetes. Even type 2 sometimes just comes. There is some immunity issues that once there is a pregnancy, the glucose goes up. There are girls with the glucoses are absolutely normal. And then once they become pregnant, they come with, in the first trimester I am saying. The typical hyperglycemia of pregnancy comes in second and third trimester, which are true GDM. So the treatment, the outcome is different. In someone gets diagnosed in the first trimester, you know this is very severe hyperglycemia. This can be frank type 2 diabetes, which is just getting diagnosed. This can be new type 1 diabetes. And then second, third trimester diagnosis GDM is standard GDM, which are that way milder and easier to control compared to other. So what are guidelines and recommendations? So they group of people come, there are expert opinions, there are some literature, very less literature for pregnancy. So many times it's more of an expert opinion. So it's basically you study what is happening and then you treat. You have your own opinions, study whatever is the things are published. Now this triglycerides coming up so one needs to be aware what is happening. I remember I was a part of the 4th recommendation international, which happened almost after 15 years. Then the HAPO came, then the 5th recommendations came. So these recommendations are not like SGLT2, which come every 6 months, but we need to have our own thoughts when you are treating these young girls. Now, when to give insulin? Just give whenever it's needed. There are lots of recommendations. This was the NICE guidelines. So they say, if you see fasting glucose less than 7, it should be maintained. You can just begin. I think I will go to this slide, which has all the recommendations, which is ACOG, IDF, and the DIPSI. So fasting glucose persistently high more than 90. So now when to try medical nutrition therapy and wait for diet. So if someone is true GDM, second trimester, only glucose challenge test or GTT is positive, fasting is normal below 90, this is just 160, you wait for MNT. And then start insulin after 1 or 2 weeks. But the fasting comes more than 110, you start insulin right away. Or sometimes there are cases that there is a macrosomia, there is a more liker when you do the sonographies at 30 weeks, and glucoses are not that bad. Still, you need to start insulin at certain times. We need to use in these pregnant girls, which doesn't decided by the glucose level. So these are the ADA recommendations. For targets. These are the targets in pregnancy. So fasting, I will say below 90, 1 hour below 140, and 2 hour below 120. That is the standard recommendations. Now, when you are saying targets, again here it is same thing, what it is shown by different organizations. There is a recommendation for A1C also. We can discuss about A1C, I think in question answers. So I'll be a bit, I was not looking at the time, I'm sorry. So these are the targets, glucose profiles in pregnancy. So insulin is the gold standard and SMBG is must. Now A1C, a few things, I think it's a very important thing that we do check A1Cs. We do follow A1Cs. I was working with Lois in Samsung Hospital, California. They just don't look at the SMBGs. Patient bring self-monitoring of blood glucose. They do A1C every week. And they decide their insulin doses according to A1C. I do A1Cs every maybe more frequently whenever it's needed, kind of to just see whether my insulin doses are correct, looking at the SMBG of the patient. So you can decide that. At the term, if the A1C is around 6, the outcome of the delivery is much better if your A1C is around 6 in third trimester. So SMBG, A1C, and continuous glucose monitoring. This is just a case about Madam, I will just take 2-3 minutes more. So this is a 38 years old lady, had twin pregnancy, 19 weeks. She was diagnosed diabetes after pregnancy test was positive. And just showing you, this was the glucose profiles at 16 weeks. So she was put on CGM. So this is another way, if it is very severe, she was IVF pregnancy with the bad history. You can see just within 4 days how it is going down. And now her hyperglycemia time reduced from almost 74% to less than 30%. So CGM also becomes very important tool like SMBG in pregnancy. So when you decide which insulin, there are categories. You know that category B is the most safe drugs. and category C can be used. So we don't use drugs which are DNX like ACE inhibitors or ARBs, but insulins, if you say, just see in pregnancy, NPH can be used, glargine is category C, insulin detamir can be used, and degludec not to be used in pregnancy. There was some label update for glargine, which is category C, but there are some more than 1,000 retrospective and prospective pregnancies are studied. There are some meta-analysis which says that glargine can be used, which is category C drug. Coming to fast-acting insulin, which has their own stay or own thing in pregnancy, you know that regular insulin can be used, aspart can be used safely, lispro can be used safely, and the fast-acting aspart, which is Fiasp, can be used because it is same as aspart, can be used in pregnancy. As we were talking about the postprandial glucose and relations with the fat mass, the earlier acting insulin is definitely better. So comes the more important of fast-acting insulin. You can try in your practice, you can use regular human insulins, you can shift to aspart, you can use lispro, or you can as in fast-acting aspart. Whatever works best for that patient. It is just you need to start using, see how her postprandial peaks are behaving, do lots of self-monitoring of blood glucose, and take your own call after a week. Sometimes regular insulin doesn't work, then you can use this fast-acting aspart, though it is a bit cost-wise costly issue. Another thing, I personally feel there is no role of premixed insulin in pregnancy. It has to be basal bolus. Sometimes basal insulin you need to give it twice, like you can use NPH morning, evening, you can use glargine if you are using, but you need short-acting insulins minimum 3 times because what you are looking at is postprandial peak, it's not only A1C. So if your postprandial peaks are under good control, your baby's fat mass will be under control, the liquor, insulin levels and the amount of liquor. One word of caution, because of too much awareness in obstetric world, sometimes your obstetrician will push you to use insulin. He will send back the patient, the glucose is 146, it's not at all under control. So try to talk to the obstetrician every now and then that there is a difference in type 1, type 2 and GDM. And if you give too much of insulin, you will produce small babies. There is a growth restriction. So serial follow-up of baby's abdominal circumference on sonography when you are deciding insulin doses is a must. It is not only SMBG. You need to have, sometimes I order for sonographies every 15 days to see how the abdominal circumference is moving. And nowadays it's AI in radiology, so you get beautiful graphs. So sometimes it's below 5th percentile baby's size. And the obstetrician is telling you, no, your sugar is not under control. So you tell him there is already growth restriction. And please stop metformin if whenever you see growth restriction in a baby after 2nd or 3rd trimester. So insulin doses are decided by CGM, self-monitoring of blood glucose, and also the serial sonographies, liquor amount and baby's abdominal circumference. Look at the sonography reports. Head circumference is different, it's genetic. But abdominal circumference decides baby's ponderal index or baby's visceral adiposity. So look at the abdominal circumference in sonography. This is my last slide. So we know that diabetes begets diabetes. So mother with hyperglycemia, there is altered fetal islet function because of mother's hyperglycemia. Childhood obesity, if she is a girl, she gets at puberty more kind of a insulin sensitivity goes down. The girl becomes pregnant, she gets gestational diabetes, and this cycle just goes on. So you need to break that cycle by treating metabolic factors in pregnancy. We know more about glucose, but there are triglycerides and there are other factors which we are not aware, which will come soon with lots of research. So using correct insulin in pregnancy, you can reduce baby's fat mass and control that abdominal circumference by controlling mother's postprandial glucose values. Thank you so much.